started.
Okay, all right, great. We can do that. Okay, you bet. Okay. I want to welcome you today to the College of Allied Health on the campus of the University of Oklahoma Health Sciences Center. My name is Kevin Rudeen, and I'm the Dean of the College of Allied Health. And I want to tell you today a little bit about Alzheimer's. Alzheimer's disease currently affects about 60,000 Oklahomans. That is nearly 1 in 8 people that are age 65 and older, and nearly 1/2 of the people who are 85 years of age and older. And these numbers are projected to grow substantially by more than 25% in the next decade. While there is no cure for this disease, helping individuals with Alzheimer's is critically important, as well as people with other forms of dementia. We want to help these people to live independently and live longer, productive lives, and that's an important goal and the focus of ongoing research here at our University of Oklahoma College of Allied Health. And thanks to a new grant of totaling almost $100,000, Dr. Carrie Ciro and her team will be able to take the next step in this very important process of research. We're particularly appreciative of the Alzheimer's Association, since this grant is only one of 3 awarded for non-drug research projects by the Alzheimer's Association. Ms. Nellie Windsor, the Director of Communications for the Alzheimer's Association for the state of Oklahoma, is with us today. And we appreciate having her present today, and we'll hear from her in a few moments. But first, Dr. Ciro, who is Principal Investigator and Assistant Professor of Occupational Therapy at our college, is here to share more information about this research and what they have learned and what they hope to be able to learn with the help of this grant. Dr. Ciro?
Thank you, Dean Rudeen. I'd like to first start by expressing my gratitude to the Alzheimer's Association for funding this award, which really allows us to move forward in the next phase of this research on an intervention called STOMP, which is short for Skill Building Through Task-Oriented Motor Planning. In the essence of STOMP is that we are aiming to first improve how people perform in daily activities at home, and second, potentially delay any decline in activities of daily living that may occur because of the progression of the disease. STOMP is a non-drug behavioral intervention, so people participating are not taking any drugs beyond what they typically take with their physicians. It is a behavioral intervention that's delivered in the home. So what is it? In essence, what happens is that we go to the home and we spend a significant amount of time talking to the person that has dementia and their caregiver, and we find out what daily activities that they have lost performance in or lost skills in that they want to regain skills in. And by doing that, we really also spend time thinking about what is it that they've lost that is at the essence of who they are. Not just any skills, but skills that are important to how they perform or how they feel about themselves as they go through their daily lives. We watch how they perform, we look for the errors that they have, and then we build practicable sequences that allow us to repetitively practice how they do the task without error. So we employ an errorless learning paradigm. That's important because by not allowing them to make mistakes, we feel like we're encoding them or encoding the brain to do the task without errors. We also build in some unique features like new assistive technologies like pill reminder watches in the sequence of them remembering to take their medications, all of which is funded by the grant. In the past, we've done this intervention in both the clinic and in home environments, and we have found success in improving daily life skills and also in retention of the skills at least at 30 months past when the intervention ended. So that's very promising. In our current study, we are now looking at what's the amount of dose that's necessary of STOMP, or how much is necessary in order to be effective. In the past, we've done very heavy dosing schedules where we see people 3 hours a day, 5 days a week for 2 weeks. Now we're going to compare that heavy dose schedule to a lighter dose schedule to see if that is as effective so that we can minimize the amount of healthcare dollars it may take to deliver this intervention. So our next phase is focused on the amount of this intervention that's needed to be successful. In order to qualify, we're looking for people between the ages of 50 and 90 who live with someone in a residential environment, like a home, an apartment, or a assisted living facility. We're looking for people that have mild to moderate dementia of any kind. We are also looking for people who have at least 3 goals in mind, goals related to how they take care of their bodies, how they take care of their homes, or even potentially goals that are related to a leisure interest they may have had in the past that are a significant part of who they are. We are currently recruiting now in the Oklahoma City area, and if there are more questions about who is eligible, we'll have information on our website or available through calling us at the College of Allied Health. At this time, I'll pause to see if there are any questions. Okay. Okay. So at this time, what I'd like to do is introduce Nellie Windsor, who the dean has already expressed to you as the Director of Communications for the Oklahoma chapter of the Alzheimer's Association. Nellie?
Hello, thank you for having me today. As was mentioned earlier, there are over 60,000 people in Oklahoma who have Alzheimer's disease, and that doesn't even touch on the over 200,000 caregivers that there are. And I believe that this research that is being held here at OU will drastically help those caregivers in their daily lives. The Alzheimer's Association is the largest nonprofit funder for Alzheimer's research, and they've awarded more than $335 million since 1982. The association grants are intended to advance the understanding of Alzheimer's disease and to help identify new treatment strategies. Our mission is to eliminate Alzheimer's and through the advancement of research to provide and enhance care and support for all affected, and to reduce the risk of dementia through the promotion of brain health. By supporting research like Dr. Ciro, we are able to do our part to help advance research. Through education programs, support groups, care consultations that we're able to provide through our offices in Oklahoma City, Tulsa, Enid, and Lawton, and coming soon to McAllister, we work tirelessly to provide the support needed for those currently caring for those with Alzheimer's. For those in rural areas in Oklahoma, we also provide telephone support groups as well as many online tools that are available. Please take a minute to look at our online resources at alz.org or call our telephone support line at 800-272-3900. Thank you.
So through this intervention, we are really aiming to improve what we call procedural memory, which is memory for how tasks are done. You all don't have to think about what it takes to tie your shoes or put your pants on or drive a car because it's embedded, because you've done it so many times over the course of your life. The good news is that procedural memory is spared for a long time in people with dementia and is usually only affected primarily in later stages. Now, in contrast to that, we often think about people with Alzheimer's disease having problems with things like not remembering people's names or who the president is or where they are. That type of memory is called declarative memory, and it's significantly impaired early in the disease process. And to date, we've not come up with techniques, especially behavioral or medication techniques, that seem to help with declarative memory. So now we would say at this point that we don't know that we have an impact on declarative memory. We are aiming for an impact on procedural memory.
How does improving that type of memory improve quality of life for these individuals?
So, for example, because we spend a significant amount of time talking to people about what they've lost that's most important to them, we then are, by improving tasks that are important to them, we potentially increase the quality of life. So, for example, somebody may say to me, it's important that I get up and make eggs and toast for my wife in the morning. That's what I've done for the last 40 years, and now I can't. That may be a task that we practice through this intervention. That maintains the integrity of that morning relationship for that couple. It maintains the pride that that person has in themselves, that they're still providing for and nurturing their spouse. So those are the kinds of tasks that we may do, and those are the kinds of impact that they may have on people in their daily lives.
You mentioned in a new study that they were looking at 2 levels of this therapy, and they were wondering how you determined those amounts.
Okay. So the first level is the level we've been doing in our previous studies, the higher intensity dosage. The lower intensity dosage is based on what people typically receive in the clinic when they go to therapy now, which is somewhere in the range of 1 to 2 hours a week for a couple of weeks. Traditional therapy now, we have kind of an idea that people with dementia may not improve. So therapy resources are very narrow now if you were to go seek therapy either through home health or outpatient therapies. So what we've done is model that lower dosage in alignment with what people would typically get if they were to go to therapies outside of our intervention.
What do you hope to learn from this study, and what next?
Well, we hope to understand how much dosage is necessary. We seem to think we have something in terms of the intervention, but we need to know how much. We need to know how much because we need to know if we need to be delivering more in the clinic, or if the intervention is solid enough by itself that maybe we can use the typical clinical parameters for dosage. So first we need to determine how much is necessary. Next steps from here are translating this from, we've primarily done this in home environments. We would love to next steps be translating this into larger clinical environments, skilled nursing facilities, places where people with dementia, larger amounts of people with dementia reside.
Is this something that non-therapists could be taught to do with their loved ones?
So on some levels, yes. So for example, we have caregivers and spouses say to us all the time, I've taken what you've shown me how to do and I've applied this to different activities that we're not practicing. There are some elements that only a skilled person can deliver in terms of determining where the deficit is, maybe knowing exactly what type of modification to apply. But the simplistic piece of it, which is practice and maintaining time doing a task, those kinds of things are the things that caregivers say that they are continuing to do or that they can do without us, and that's making a difference regardless of whether a therapist is present. So this is our third trial. So we did a clinic trial where we had a number of people participate here in the College of Allied Health. Then we did a home trial here and in the state of New Mexico. And now this is our third. It's been probably, I guess, about 4 years now. All right. Thank you.